So welcome to this session on the ethical considerations related to diversity and inclusion in emergency medicine. This session originated from the Ethics Committee, the SAEM Ethics Committee, and it's sponsored by the Academy for Diversity and Inclusion in Emergency Medicine. Our panelists. I'm Eric Isaacs. I'm going to moderate and be chief learner with you in this session. And I'm going to have each of the panelists introduce themselves, if we can.
Sheryl Heron, Emergency Medicine at Emory University School of Medicine, one of the vice chairs and full professors, and assistant dean.
Aasim Padela at the University of Chicago. I am faculty at the McLean Center of Clinical Ethics there, and associate professor of medicine.
Joel Moll, residency director and associate professor at Virginia Commonwealth University. I'm also, for another day, president of the Academy for Diversity, Inclusion, and Emergency Medicine, and then will be past president.
All right. We have one disclosure.
I just have one disclosure. I almost forgot my disclosure, but I thought it would not be ethical in the ethics session to not have it. So the Diversity and Inclusion and Quality Patient Care textbook came out a couple of years ago, so thank you for those who have read it, participated in it, and we'll be having another textbook coming out really germane to this section, which is about your story, our story, and the microaggressions and unconscious bias that I'm sure we've all either felt or witnessed.
So our objectives are to describe ethical challenges posed to students, residents, and faculty in managing the racist or biased patient. Also recognize that there are ethical principles surrounding the impact of a provider's biases and their personal belief system on care of patients. And then we are going to be listening to the experiences of others in this session. We have 3 cases on the slide set, although we expect we may just get through one. And so those other 2 cases will be there for you to study and think about as you go home, because you'll have the slides available to you. And if we get to them, great. We're going to actually try and use some hypotheticals to get to some of the concepts in there regardless. You have some index cards, and these index cards are going to serve a couple of purposes. One is, I believe that as adult learners, we learn more if we put our nickel down before you hear the answer, so you have to sort of engage and think about it. So after each question or case, I'm going to ask you to write down what you would do, and then we'll have a discussion about it. The other thing that we'd like you to do with the index cards, while we want this to be a safe place to speak your mind and to listen to the experiences and opinions of others so that we can have a conversation, there may be some things that you're thinking or feeling that you don't really want to attribute to yourself. And so if you want to write those thoughts or questions on an index card and pass them to our student ambassador, we will try and mix up the cards so that it really is, we can't attribute to anybody, and read those out loud so we can hear the ideas and thoughts that people are having and talk about them without people having to be self-conscious about raising that themselves. Our goal is to make this conversational and engage you as the audience. And so we're going to try and do that while still raising the points that we feel are important and wanting to hear from you. So there are really no right or wrong answers here. One of the things I'm keeping in mind is I'm thinking about my background and identity that I bring and the lens that I see things through, because I know there are a lot of things I don't see because of the lens I wear. And so hopefully you'll also consider that yourself as you're hearing the opinions and experiences of others to better understand each other. All right, so I'm kind of a framework guy. And as you see these pictures, you have a trauma patient, you kind of have a framework that you know how you're going to take care of that patient. And you're going to move through that framework, and there may be some things that are really important or that are significant, and other things you could pass through. The airway seems to be fine, breathing seems fine, but circulation, we need to work on that. And you work through that framework. Similarly, with a patient with this arrhythmia, you have a framework that you work through, that you've learned and you practice. You learned it sort of in one setting, and it became a little bit more automatic so that in the heat of the moment, you can apply it without too much mental exercise. So similarly to ethics cases, we're going to give you a framework to use. This is one of many frameworks. This one was based on Swayze and Bird, adapted from some other publications. And it's basically one way to think about ethical problems. In the emergency department, we don't necessarily have time to go through this framework step by step and consider all the steps. But with enough forethought, enough experience, when you are faced with situations that you've thought about before, you'll have a path to follow. We're going to go through each case with frameworks. I'm going to go through a little bit quickly. So the first step, if I don't cast a shadow, is once you're faced with a situation, and these ethical situations arise because there's a compelling reason to do the opposite thing or different things. So state, what's the issue or question that I'm trying to answer here? Then identify and clarify terms, facts, the stakeholders, the ethical principles that may be involved here. Then after we've done that, do we need to reformulate the question, or do we think we have a good question to deal with? Moving on, think about possible solutions. We're pretty good at that. Consider the implications of your decisions, the constraints of acting that way. Decide on a solution, and then intervene, act on it. And then hopefully you'll have a chance to reevaluate it and maybe tweak it a little bit along the way. So that's one framework. We're going to kind of refer to that as we're working through our cases. In terms of the reevaluation, it's, were there other options? Why would someone disagree with you? Do you still think your solution's best? Other practical compromises. That's one way to reevaluate, continually reevaluate. All right, so our first patient.
So good afternoon again. So before I start, I just want to ask if anyone in this room was present at the ADIEM pre-day where we talked a little bit about how to handle, just a show of hands if you were not there, so a couple people. All right, so first of all, I want to give kudos and thanks to Alden Laundrie, who actually presented a similar case that day for those of you who were there. And this particular case, you can read it there for yourselves, is a real case that actually happened to me while I was working at Grady, which is where my clinical practice is. And it really was about a 40-year-old male who came in after a car crash to our trauma center, had bilateral deformities, as you see there. He was demanding and seeing a physician. He had a swastika there, declared loudly, literally, in quotes, "I don't want to be treated by no nigger." So I stopped there and I asked you to just fill in the blank for you, right? So this is my personal case, and I asked you to reflect on if you have seen something or felt something or heard something. I don't want to be treated by no nigger, gay, woman, trans, Jew, spick, whatever it is, right? So this is going to be about us working together through some of the ethics and discomforts about what you might encounter. So as you see there, everything looks fine, stable vital signs, GCS of 15, just for kicks if you're wanting to know if he's altered or not. Awake alert, clearly talking because he was able to tell me who he did not want to be treated by. And so really what we want to do is stop here, pause, reflect, and in the constructs of the ethics framework that we have heard already, to consider some of the realities. We know, just in terms of background, that there has been a lot of information, whether in the pop media or in written media, about racism in medicine. We know and we have seen, if you have not seen, I don't know where you've been in terms of Tamika Cross, our OBGYN resident who was on a plane and was told by a passenger on Delta that why you here was a flight attendant. You're not a doctor on one's credentials. You may have seen or have heard about a nurse from Flint, Michigan, who actually sued the hospital because they were acquiescing patient who did not want to be taken care of by a black nurse. So there are many, many scenarios that have populated our literature in terms of racism in healthcare, or the pop media, CNN, Twitter, whatever, about some of these things. And so in the framework of this, and hi Alden, thanks for coming, Alden. I want you to think about it from the framework of what we discussed. So
if we ask ourselves the questions as you see there, what would you do, what are your options, and what are the ethical concerns? We're going to try to walk through those.
Let's take a moment
to think about it.
So think about it. I want you to write down on one of those index cards.
Right. What would you do?
What would you do? You are the only who will.
What did I do?
Yes.
Yeah, to that point, I'm just curious.
That's another option.
Has everyone in this room experienced a similar situation?
Yeah. Or sit.
Pretty much exactly. I think that was
Oh, okay.
Yeah, okay.
He's been hospital shopping, right?
breaks his arms and comes to see the guy.
Yeah.
A minute or so. I'm wondering what's an issue that we need to hear? What's the ethical issue to deal with here? Willing to say something.
Okay. So what about this patient? I mean, what's the conflict?
And the need to provide care to the patients in the environment.
Okay. So we have a patient that's offended the physician, to say the least, and patient needs care. So what do you do? Yeah.
It's more like a of care, or is this somebody who's really upset everything and just having a horrible racist day? And I think there's different acts that you could take for that standpoint.
So, Matt, just for point of clarity, when you speak, could you just tell us who you are? Because we're recruiting, and I'm just kidding.
No. We,
Just
yeah. So we're not going to your name because we're recording.
okay. No name. All right.
We want this safe space, so please your name.
Yeah.
Sorry. That's it. All right.
Erase that from the tape.
Yeah.
Okay.
It's like Nixon.
An ethical issue that arises is patient and health to take that. Are you going to give the patient the thing they want, even though it compromises their ethical considerations?
Other thoughts?
Can I just ask? So there's a question. I made a point. I just wanted to, about negative implies or obligations or duties. So if someone's saying a question, I want something, that places under a certain type of duty or duty, right? It's a negative right not to do. Someone's saying want something, and that's creating a positive, right? So when you work through or any other case, you have to do an emphasis. Am I being asked not to do something or to just negative or positive obligation that I'm being extended?
One other wrapped up. This is like now the provider is completely against this patient, and I ask myself, can I give the best care in this scenario to this patient?
I think that's really considerate because our own, it's kind of like your pulse. The same circumstance for this, because you are going to have to be objective, and recognizing your own bias is important as recognizing the biases this patient has.
Any other thought?
Yeah. You also understand what the intents are. Should be racist and inflammatory. Reading the statement sounds and looks like it acts like a duck.
is a duck. Maybe it's not a duck. Maybe that's just, nowadays the word nigger used liberally. This is something that is completely from where we are, and so we'll clarify as well. Work with this, and why is he coming from this? And maybe once and send his swastika on the guy, that kind of makes it less. That is the positive of this, but once you determine that it's out of the pot, you have to make a decision what to do.
And are you giving benefit to that? No, but I mean, to that point, I mean, no. So, when you talk at the pre-date, there was a picture of a house, and it was assumed, it was a certain ton, and so that's a really good point.
Yeah, just some facts in a second, but I don't know if many that, my family, part of my family is India, and that's a very in India.
Actually, one uses the left hand.
It's just, right, it's the point that we might say something, and Sheryl made a point, you should say, identify as race. It could have been something else that we're now interjecting our own meaning to some way. So just pause. We'll go right, but just pause for a moment.
So good on. I think we for a couple of when we often don't our patients. Anybody ever, some of you know, is a child molester or a number of things. We don't really get. That's not what we signed for. To love all of our awesome if we. That's not what we signed up for. I think you also look for what are equivalents. So if preference, if a woman asks a woman, is that horror to make us mad? Well, the only woman and 15 women come in at that, you're a little frustrated as a 10. It's awful as this is. There is the issue of I don't get to love patients. What else do you ask us to do? Really struggle to do. What is the hierarchy of women remains at the top outside of it, indicate work. And for these year, which is an obvious default I get to do, is to can't practice about my team. So I'm able to give care with a team, and this is my team. Then now we're having that at least a little bit, because this for you, I want to sew and care of me heart attack. If this person has nothing wrong with them, great, you can. I hope you have a hospital where they can give you what. There's nothing wrong, but when there is a death relationship, that you have to have care, and so the hospital already had a policy on that.
So since we are walking through, and this is good. Get the mic. Going back and reflecting on your work, how we are coming to some sort of and conclusion discussion. Keep at this. Ask yourself a question. Have identified what is the question, right? And I think we're starting to have a conversation. Who are elders? Who acted? Who environment that you're taking care of? What is, as physicians, right? Is there a hierarchical reality that you hold as physicians, as you think about this? Principle of the terms. I think it's as we look at such frames, we're thinking these things, the blind power of patient men, that while we are to act and react with systematic, I'll ask Aasim your thought on that sort of.
No, I think it's one of the that we saw. I was trying to introduce a couple of stories because what I'm saying to all of us, and particularly in our environment, that we are very good at finding solutions and acting on what's happening. We're not systematic, right? Mm-hmm. The only reason this ethics, because when I do ethics classes, sometimes come to this solution because of you brought through having all the factors together on the table. allows you to. So I don't. The thing I would ask. So, well, I don't actually hear from the group the questions, right? The question. Can someone make a demand upon a provider pool? Is that the? Is it legitimate, ethically justifiable? Is your request for provider? Is that the question? Go through some rubrics for that. Mention autonomy, or else it might be. Is the am I change that I deliver care? Right. That's the question. And is that justified or not? Do I do that for people, not for other? We have not gone around with questions. Right. Questions about feelings. So for us, our decision here was for us to get out. Then you can start generating solutions.
Right.
I thought kind of pigs with Mike and actual need to want to initially. The thing that my brain, I hear that it kind of off there, the goes to my brain, and it's like, okay, well, we treat it. So I need to figure out a way to go. So that's first come to my brain. You be treated by go. That's not what necessarily comes through my brain. So the question is, patient or not? That's ethical dilemma. Or not.
Right. Now, Cheryl, where's
exactly.
Right.
So now,
I'm going to finish one more. Sorry. Kind of piggyback back on that. So once you determine that, then I think the gentleman back here is sort of now trying a stack and really trying to have a conversation with the person where they're coming, because right, you're bringing in your own assumptions, you're bringing your own thought, what you want to do, but really you don't ask. Maybe he had that experience with in his life, or something happened to his mom or his dad. Have the full have an understanding this person. You see, and a guy using derogatory term. That's what you still need. A staff. You need to talk to that person, so you don't bias your own anger aside and have a just stand with that person coming.
Okay.
Actually, that second comment was my when I actually has more than once is Ferguson. Can I help you? And start a conversation. Huh? Oh.
We're all safe here.
Right. We're safe here. And I think the question is, you have a duty to treat. He came. There was no as a physician. You took that. You got your. That's not a question. This person. The question is how open it up like any other patient. I would treat any other patient. My name. A little morphine for those different arms you have, and start the conversation. It's very
lot oral.
I start pain medication. It's very late. I like some morphine, but at least I have a conversation started. This will get him to let us in the morphine. Start IV, and all this happened without me even my eye. And the nurses will just, and now we start treatment. I go try at this point engage in the conversation and bring it back. If he keeps saying I don't want you to treat me, actively decline. Say he didn't want me to treat. He didn't say he didn't want to treat. I'm not a nigger until he. I you to treat me. I'm going to go ahead and do for that moment to come or not.
So as physicians, we have to treat, right? I mean, I don't know if you're a New England medicine's article that taught to deal with the relationship, right? They give very clear sort of guide you all as to care as to our ethical treat patients. Any relation or department, right? And so if you look at a friend, you say identify our term, fact, statements, principles. what would you do? And you started to say, right, it's whether the patient or not, right? Right. Right. So don't know, right? And it's like maybe they neurological have under the influence, or they and share, talk about what's that happening. Question becomes, they're stable. You're hearing stakeholders, and by the way, with everybody. So this was not a private conversation. There are some states there. Right? So that's the question. We do treat or not. Terms, stakeholders, principles. Whose principles?
Good question. It's important. So many people saw this interaction.
So, play that, please.
Social media and how media is capturing everything, and then like, I didn't know that was happening. I didn't know that you deal with daily basis. So I think it's important for to see this interaction because people, when you people think have happened, you interact, think you're straight a little, and you need people one validate what you have seen, your experience, so they may be able to, especially help for everybody to see it, for the and be able to, to the residents through it, to be able to residents about, it's for people to see this thing. There's no doubt of its presence and people openly. And one also people heard what's happening because when with the court as they need to, for example, something has or this guy, the person, appropriately or happen, it's a word in his word. It's also helpful for other interaction as well, for the purposes.
So you said the court, so do you concern about, so.
I didn't say court. I meant like the person came to complain or said something about how him.
So your court, this is other people interact.
Like,
But this is, I think, it's beyond that. It's a comment. Sorry.
So my concern with this being is, okay, if disrespect this time, I mean you're disrespecting else the net, and you know what I'm saying, or just like a free for out to you can anybody any name possible. I don't expect to come to work respected. I don't expect to come to work respected. I don't expect residents. So is that something that we're allowing now as a hospital?
Message does it send?
Yeah.
Leader are affected and do nothing. One of your team and you do nothing.
So I think it has to be addressed. How it's addressed is vital.
So
No.
So as we think about it, right? There were terms that people said. One was must or should. Right? That's the start of things that I'm blind to. That's good. As some sort of date or ethical.
Mm-hmm.
So the question out is there a mandate by individual belief system? There is no should or must. Is it must make sure everybody else on position to maybe who's in the ED staff are flourishing environment? Right? I have a lot of negative experience in position. If there's 50 people in the waiting room, I walk in the door. But when I use the terms, I'm trying to conduct, we are playing field, different sort of shoulds and desires, right? And what I not do. So I'm saying that because you guys say, okay, well, what I do, right? The duty to treat, Allah, right? And what is sort of bull, right? The person has sort of I said, I felt this, go to some of the ED. I'm right. Medicine again. So I just want to. We're in an ethics. I'm just that we're using creates obligations that we shouldn't or want to. But when we're saying there's a position that we held sort of either assumption I don't do form.
Might be digging a little deeper, but when I hear about how this is targeted to one can affect else, is like a clear macro, not even macro towards one person as a lot of present. I think about debriefs, seeing a little trauma or and make sure everyone is okay. Similar, like the physician charge has a responsibility to debrief the team, and that is played on experiencing trauma, but team emergency medicine being very theme-based effort. I see it must not go as it should of how it deeply affects people.
Yeah. So, yeah.
Code is a clear code. When is it? I mean, I just walk in the door and go for it. Agree with you. I'm saying this code, do I call 15 minutes? We'll have that.
So go ahead and then I'll comment after.
No, go ahead. This is tangent.
What I'm hearing and what I'm getting to it in the ED patients is right. That and wouldn't be being meant violent as the physician, health care, whoever. And so if that's a question, right? So it's looking at the care and with all this, and we have an effort to treat. Do we have the ethical that we should use? Is that a question?
Are we
willing to take that thinking? You're saying why we need to respond to that, or should we?
But I think you need to define that abuse, right?
Well, healing, you take care of the patient. Back from what I'm hearing of everybody, should I sense and say nothing?
You take care of this every day.
Okay.
Usually is for this. So is it was the abuse he let you?
Nice.
Nice. That abuse that I'm looking at who are looking at me, you better damn well send Oris. Because I'm
exactly
right.
So
well,
I think in your I've heard it. A little bit of detail. But I think, look, I am capship at a teaching institution. The hat as a doctor patient. I am bringing in, right.
Obviously, no, Dr.
Yeah. So
I'm just thinking one of the things that cross terms of the ethics of what I feel in any other sense I apply. I have obligation to enforce conduct. My emergency often stand code of, which I make in real time because I don't know how to actually read, but I try to use that as a tool which to these behaviors that may microaggressions to my peers and myself. We all ourselves in a certain way in this piece, include as a patient. So I like using this kind of language. And so I kind of address directly and very unapologetic unapologetically, profanity, volume there, or music, or try to govern the environment in that way, the content, and certainly in these kinds of.
So your solutions, right? So we're
it's exactly what he mean, right? We didn't answer that saying first not or he no way to actually get right the situation, right? One is against medical care, obligate that individual. What's going on? Coverage in town. You know, are you use care and you would be a violation of your solution? Saying that you're not choice. I think they're very different. Dig a little bit deep. You get it with the patient. Not just, you know, the end can be lots off to our nurses. Hopefully, they will leave a may because they have to adjust and set the.
Put out there that he may just be a jerk. I mean,
right.
Yeah.
Once you start takes the care, but it's very important to be refusing or is saying that he doesn't like you, prefer you.
Okay.
Raise, so we have about minutes to go. Yeah. Well, I after if we should reassess where we went.
So the conversation you guys have written down. Just share one that's important. You work through this, which we're not, but the notion for us, you know, a lot of you that's fine, right? What's happening, and what then the other has to do with something. How am I comfortable? You know, I feel dominant. Anybody walks in that door, care. I'm just gonna, no matter what, you know. I guess in this stuff together. Right? I'm not willing to take that. I'm not willing to take myself. Because my quality good, right? Someone mentioned that because that's a tactic. Our propels, but we also have in our we're thinking that there are two. I mean, moral agents. That person and maybe there's others are and come to that convolution. It's all at the same time. Think about us as usually to do, and as a, which is sometimes in the end, but we're gonna have nicer sort of. They're willing to take. I'm not gonna be else in the you know. I'm the captain here, and they'll provide down the stair about the solution that we have to identify not ourselves. We know what we're when we move the piece of we need to do that. Acting and not acting. We're just reacting.
And I'll turn it over. Where we land, things to add about is, do you do? There has, we know we come in, we have a protocol. We sort of, what do you do? Why should we do that? Each be different framework within the hospital or you reside. If you walk, say, since 2016, then you need to prolong what we've been. So we have to be clear about conversation, which is going to talk about, because lots of there are the right. There are many people you should never be. in the session on the putting as a belligerent, so can flag somebody who is feign and stress disruption. That is one way that it needs care still flag and sure and come until it receives some documentation. And there's right. Cut you off.
And I hate to open worms. It's sort of there use math that next time back on their chart, but in their back they were just drawing and labeled so has as start to digress.
That's okay.
Okay, I just wanted to an extension of the ethical racial bait requested. That's the main question here.
Some PD, I think I did. But is that example? There's a 20% accordance, and at least in terms of more stable relationships there, better quality. I don't know about the outcomes. Quality metrics important racial in America. In terms of Hispanic, right? This is population accordance to phenomenal in patients adherence to diet control medicine. Maybe food thing they don't know, but they're the outcome. Physical relationship. So know that that's tangible. Providers of health have to not that there are some benefits through different maybe. But the fact is that there are benefits true from relationships. Ask?
That's
right. So what are you about? What's there? Right? Everybody talks else. Talk about patient. Enter the ED. When you enter the Bill of Rights, that language discourse American. So Howard at time can request any time. So where we.
On all fairness of obligation, we do.
Right. And there is, the satisfaction.
Right.
Flint. They're like, all right, yeah, bye. There is this tension between what they do. Is that become a physician who's white? As I said, I want to be taken care of by a white. I don't want to.
I want the best clinician, the most. I years, right? This patient,
right?
They want the most.
That's
He's the most experienced is not me.
So, and what are policies and Alex to a
just in terms of the 5 categories. One, I guess one is avoiding, and that's besides that would be accommodating. Those seem like even on the table. Totally avoid the issue. You are not going to just roughhouse the person that you've been not going to happen. So it really or collaborate. And I'm is a little like distributive negotiation. It means you walk away people are, and that part of result. So I see even in this egregious, has there been a
yeah. I mean, so sense that he got best. Now I had the interest. Yeah. So I question with the card. What am I supposed to say now? I am, and I'm just want to go down here, but I can't do that. Right? I meet him, and we do language here to professional ways, and you're very don't tolerate because professional you underneath my you don't want but actually looked and was shocked he was expecting. And I'm really sorry. He acted fine, and you can everybody else felt that situation of this is how we're going to. You are more not happy with services of. He had two doesn't really.
But at one point, I want. So that you compromise by providing, right? It would have been that this might have been much, right? Is that what you're trying to?
I mean, the reason you wouldn't because person, Ostica, they're not change. People like if you're part of your, but you also listen. I'm going to give you best care. All my other.
I would say I understand how you. I don't understand. I just.
Yeah. And no matter what, angry at me. Right. Then, gosh, this person unbelievable.
Right.
Did make them better. A little beyond the down.
So league that femurs would said, okay, well, give you pay money, be taking care of me. I want to try. What do you have? Some of the money.
I mean, the algorithm is really as you go down with the article, and the point has options. And if you don't want to be treated here, and he can make ready to go, and I will you leave. Your options. Sign out and stop treating them like people, like whatever.
Chances are he.
So I'm asking Sheryl. The reason I'm asking is so I think the journal is good. I think trying to on. So where would right, because of who you are, right? Other people like that, blah, 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 or someone are going to do or class. You have to be able to say my break. Where would I'll with one incident in New York, a patient said, and I didn't, and I said, taking care of them. She said, take care of that patient. Happened only a few weeks later. What? Say anything like this situation. Take care of that patient. Response is, and why? What was there? The person didn't need. There's a point where that wasn't
Closing was the those decisions, progressions, right? Holistic. And wow, without live or feel best work if they're not.
Not just take a room supported it different, things important. That can be
This also has to be up front. I learn how to temperature only if you're outside your compromise.
Right.
I'm sure he, but
Yeah. Yeah.
prior station, the obvious weakness to that particular.
No, we were, but ED extremist, and it was, I don't want no niggas. I don't. And acted on where I'm zero, and then of course looks at you anyway. So
this, but I'm I hope is shown some frame for yourself, determining tolerate continuum. Do you log one action versus this way? You to but to more exactly do they mean when are made and things are said. Last comments.